Today's talk is about Omicron, what we know. Let's see, just to remind everyone, this webinar is being recorded. Everyone's in listen-only mode, but we do encourage you to ask questions. So feel free to use the chat function. And we also have some questions that were submitted before that we'll be going through as well. So I'm going to introduce you to Dr. Aaron Weinberg. Aaron, if you want to maybe give a brief background about yourself.
Sure. Thanks, Caesar, and good afternoon, everyone. It's nice to be on this call with everyone. I'm Aaron Weinberg. I'm a pulmonary critical care and internal medicine doctor. And before joining Carbon over a year and a half ago, I was at Cedars-Sinai in Los Angeles on the academic faculty, doing both teaching, patient care, as well as clinical research. My area of research at the time was blood clots, DVTs, blood clots in the legs, and pulmonary embolism, blood clots in the lungs. And then when COVID hit, just like a lot of people in the clinical research space, a lot of us pivoted to go where the demand and the need was for society. So got involved with some of the early clinical trials, both with artificial intelligence, as well as with some of the NIH remdesivir work, and then joined Carbon. And I'm at Carbon as the National Director of Clinical Research, and I also help with some of the medical direction for some of our new programs. So nice to meet everyone and happy to answer any questions.
Yeah, thank you. And I'm Caesar Djavaherian. I'm an emergency medicine physician by training. I was at New York Presbyterian, where I studied evidence-based medicine and medical informatics. I'm one of the co-founders of Carbon and currently the Chief Clinical Innovation Officer. And very excited to kind of talk through Omicron with this group. A little bit of background about Carbon Health. We're a nationwide healthcare provider. Our mission has been to bring the highest quality healthcare to everyone. So we want to make sure that, regardless of your status, connections, that you have access to great healthcare and a good experience in getting it. And so by choosing Carbon Health, you're really bringing the best healthcare experience to your employees as well, if you're making those choices for your company. We are more than just actually a COVID specialty group. So we are your urgent care, your primary care provider. We focus on women's health, LGBTQ plus health. Most of our clinics, if you live near one, have x-rays. We do occupational medicine, and then we help with referral navigation, which means that if you're being referred out to a specialist, instead of just saying, well, here's a phone number to call, we really try to make sure that we get our patients to the right care, that in their, where they live, it's the care that's the highest quality and frankly, generally the best value that you can get from it. And one of the things that made us go on this journey was, similar to what the World Bank has highlighted, which is that 90% of healthcare demand can happen in the primary care setting, and only about 10% of the healthcare needs really need to be provided in the hospital or in specialty care settings. So that's motivated us to really focus on providing the best clinical demand, clinical care in clinics possible. So this next slide gives you a little bit of background about what we've done as a company. In addition to the amazing work that Dr. Weinberg's done in getting new therapeutics in the market for coronavirus, we've been at the forefront of this pandemic response really from the very earliest days. We had our first coronavirus patient end of January of 2020. That was probably one of the first cases in the nation that was identified. And since that time, we've provided over 1.5 million vaccines, over 2 million COVID tests. We've been working with government organizations, everything from local government to the White House, on pandemic response, vaccine distribution, mass vac sites. And then through our network of clinician scientists, physicians, we've also been really kind of scouring the literature that's coming from around the world. And we're distilling that information for our partner organizations and sharing it on these webinars. It wasn't until I saw this picture that Shane had put together that I saw that there's a McDonald's next to my face in that, in that interview and on TV. So I'm in no way proponent of or supporting McDonald's work. So great. So I want to jump into what we know of the Omicron variants, and this is a nice little graphic that can go through some of the some of the differences between the Alpha, the Delta, and the Omicron variants. And Aaron, I don't know if you want to fill in at this stage of what we can treat and transmissibility and symptoms and what we know.
Sure. And there's still I'll just say there's still a lot we're still learning. I think this is an evolving field, and sometimes it can feel like, the goalposts are moving. And I think it's because none of us have lived through a pandemic in our lifetimes to this magnitude and degree. And the second thing is, it's a new virus. We've never really faced something like this before in terms of this particular virus. So, I think being on top of something is the ability to adapt and to modify our approach as we learn, as we get more information, and to really be driven by the data and the evidence, and then update our guidelines and recommendations accordingly. So it's, I think it's been unfortunately construed as not, certain organizations maybe not knowing what they're doing, but I think it's really actually just a sign that things are moving rapidly, that we're getting constant influx of data, and we're updating our recommendations accordingly. So, there are some characteristic differences that we've seen, and, there's been a number of variants that have taken hold around the world. Everything from Alpha to Omicron, and we do know that the transmissibility, meaning the ability to catch the virus and spread it on, has increased as these variants have gone on. And that means that it probably takes less virus to actually catch it. So it doesn't take quite as long of a prolonged exposure. And it also probably takes less virus particles for a person to actually catch it. There are some subtle differences in terms of symptomatology. However, I'll just kind of caveat this by saying symptoms vary greatly amongst variants as well as individuals. So some patients have hardly any symptoms or no symptoms at all from all of these variants. And then some have very severe symptoms and end up in the hospital and unfortunately passing away from all of these variants. So I think it's important to kind of know that every individual reacts differently, and the presentation could be different for every individual. And, it's really hard to tell just based on symptoms alone whether someone has coronavirus or whether they have the common cold. So I've seen a lot of discussion out there on the blogs of, I just think I have the common cold. It's really impossible to tell the two apart. So I think if in doubt, it's always best to get checked. But some of the earlier variants tended to report a little bit more loss of taste and smell. However, if you look at population data, the amount of patients that actually lose their taste or smell is only around 10%. So it's still a minority of patients that experience that symptom. However, with Omicron, we're seeing less reporting of loss of taste and smell. Some of the earlier forms had more maybe GI upset than some of these later versions of the virus. However, with that said, it isn't impossible to still experience that. I don't know, Caesar, if you have anything further to add on the symptoms. I can get a little bit into the treatments if you'd like.
Yeah, I think that the narrative in media, and frankly, rightly so, is that Omicron in general seems to cause some milder symptoms, more sore throat than headache, which is what we were seeing with Alpha and Delta. But to your point, Aaron, they're all kind of still in this minority of overall cases. But because of the sheer number of patients who are being infected, we're still seeing people who, again, because even though they're the minority of patients, the total numbers are so large that that minority is still overwhelming health systems, clinics, demand for testing, all the things that we worry about on a nationwide systems level. So
Yeah.
it does seem like treatments and vaccines are kind of play a part in this variant discussion as well.
Yeah, no, absolutely. And we are lucky to have many more options than we did when this pandemic first started. I think it's really remarkable, being someone that's been in clinical research for a while, you know, the progress we made in such a short period of time. And it's really remarkable how many organizations, companies, individuals who participated in these clinical trials came together to really make this happen so quickly without skipping any steps. I always like to reiterate the point that it went through the normal, rigorous clinical trial phases, all 3 phases of clinical trial, including decades of preclinical work that led up to the backbone of these therapies. So no steps were skipped. However, you are able to perform clinical trials a lot quicker during a pandemic because you have so many more patients to enroll into those studies, and you get meaningful results a lot quicker. So early on, we really had nothing. And then we started to develop some initial therapies, some therapies that were initially used for some of the earlier variants, whereas a drug called remdesivir, which is an IV antiviral infusion, which had some benefit in the higher risk patient population that was mostly given in the inpatient setting. However, now there is some opportunity to potentially give it in the outpatient setting as well. Steroids were another thing people tried, because not only did you want to try to suppress the amount of virus that gets replicated in your body, which makes you sick, but you also wanted to prevent the robust inflammation that occurs as your body reacts to that virus. So a lot of the clinical course that we saw very early on in the pandemic, where patients caught the virus, they started to get sick, and then by week 1, they really had that clinical deterioration where they ended up very sick in the hospital and going on a ventilator. A lot of that had to do with the inflammation that occurred in a person's body affecting their organs. So we tried certain anti-inflammatory medications, and there were some trials done with good old steroids, which are a common medication that we've always used. And there was benefit in the right patient population. It really wasn't recommended for outpatients because the benefit wasn't found, but in the inpatient setting, those that were on oxygen, there was clinical benefit in terms of outcomes. And then there was monoclonal antibodies, which emerged, where we were able to produce antibodies, which are your body's own proteins that latch on to the virus and help neutralize it and clear it from the body. We were able to infuse that into people, and that also had good outcomes. Then with Delta, we had a number of the same therapies, monoclonal antibodies. There were more versions of it that emerged. However, what we found was, because monoclonal antibodies are very specific to certain variants, meaning that they target certain spike proteins. So if there are mutations to that spike protein on the surface of the virus, some monoclonal antibodies turned out not to work as well anymore. And we're really seeing that with Omicron, where some of the literature coming out is suggesting that some of our past monoclonal antibody therapies are no longer probably effective or greatly diminished. But at the same time as that happened, we had the emergence of oral antiviral pills, which was a big breakthrough, because the key to any treatment is to get it on board as quickly as you can once you get the virus, because you really want to cut down the virus's ability to make more copies of itself. So the nice thing about a pill is you can call it into someone's pharmacy and they can pick it up very quickly. So Those emerged. There's Pfizer has Paxlovid, and then there's also Merck, which has molnupiravir. And we can get into more details on the differences if anyone's interested. But that is a potential breakthrough, and I'm excited to see how they benefit patients in the real world.
Aaron, on that one, with the new kind of exciting oral antivirals, and I know that you're part of the clinical trials that got them approved. So thank you for that. But I'm curious. So if a patient shows up at their local clinic and actually qualifies for an oral antiviral today, what's their chance of getting access to it? Do you know?
Yeah, it's a good question. And, it depends a lot on the region and where they are and what the supplies are at those pharmacies near them. I've heard different stories. Some people had no trouble getting them. Others have had more difficulty. So it is still an evolving situation. I think the way that those antivirals have been chosen to roll out is similar to the way the monoclonals were rolled out, where it was done through local governments, and then the governments would decide where those were distributed. So it's kind of going through those chains of commands right now. So some pharmacies have it and others don't. It just depends. But to your point, it was really exciting. Carbon was involved in the phase 3 trial of the MPhil, and both for the treatment study, where we were able to test how effective it was, and then we're also still ongoing involvement using the same pill in those that are living with someone who has COVID to see if it reduces the risk of infection as well as the severity of infection if they were to catch COVID. So we're very excited with our involvement in these important clinical trials.
Yeah, and I know that a few of our clinics have access to Paxlovid, the Pfizer oral antiviral, and I know that our team is trying to get access around the country to those medications as well, so we can help distribute.
Yeah, and I will say there are pluses and minuses to both of the pills. There's also different efficacies. It seemed like in the clinical trials that Paxlovid did a little bit better in terms of the effectiveness. That was in the high 80% range in terms of reducing hospitalization or death. Molnupiravir was lower. It was in the 30% range. However, I would say that, both do have a good benefit if you are able to get on them early on in preventing severe infection and death. But there are some differences. For instance, Paxlovid, while I may preferentially prescribe that due to its efficacy in clinical trials, it does have a lot of drug-to-drug interactions with very common medications that people tend to be on, cardiac medications, blood thinners. So if it's a situation like that where you really can't be off of those medications for a period of time, then you may want to choose an alternative medication such as the MPhil. So there definitely takes a little bit of clinical assessment to figure out what the best therapy is for you. And then one thing, sorry to ramble on, Cesar, but one thing I failed to mention on this outline is the benefit of vaccines. And I don't know if we're going to get a little bit more into that, but that's been a huge benefit and breakthrough. And now that we're seeing a lot of real world data on its effects, including some studies that came out today, I think it's important to highlight the benefit that we're now seeing.
Yeah, so actually let's go to the next slide, which is our Q&A, and I'll stop the screen share and we can kind of talk through some of these questions that we have. But let's start off with the data that you're talking about regarding vaccines and their benefits that came out today.
Yeah. And I think it's important to realize that while there may be some features of Omicron that tend to make it maybe slightly less severe, it is a severe variant. People are still ending up in the hospital and dying from it. And it is very severe also to those that are vulnerable, that have certain underlying medical conditions, that maybe can't be vaccinated for certain medical reasons. So, even though there's been some discussion about it being relatively less severe to the other variants, it's still a very severe virus, and we need to take it seriously. And I think some of the lesser severity that we're seeing has to do with the fact that a large percentage of patients are vaccinated now and boosted, and it is having a clinical effect. So two studies that came out or three actually that came out today. Two of them was looking at CDC data, and one of them looked at 88,000 hospitalizations. And those that had the initial series of vaccine and were boosted, they found that it was 90% effective at preventing hospitalization during the period of December and January, which is when Omicron was raging. That was compared to those that just got two shots, the initial series. So those that just got the initial series and were about 6 months or more out, it was only 57% effective. So I think what some of this data is now showing is vaccines are effective compared to those that don't get vaccinated in preventing severe infection and death. But we're also seeing that being fully vaccinated also means being boosted now. There was also another study that looked at about 200,000 patients that went to the urgent care and ERs, and they found that those that were boosted had an 82% reduction in emergency room visits or urgent care visits from COVID, compared to 38% who just had the initial series 6 months or more later. So again, another study that shows being boosted is really beneficial. And then lastly, there was a JAMA article that was published that looked at 13,000 patients with Omicron. And they found that the odds of developing symptomatic infection, meaning actually having symptoms, was 66% lower for those that were boosted compared to those that just received the initial series. So you're more likely to be asymptomatic, according to that paper, if you get boosted compared to having symptoms if you don't.
So Aaron, I guess I'm going to jump to one question that's come up regarding vaccines, which is, now that we know what really being protected with against Omicron is, which is, to your point, not just the initial series, but the initial series plus a booster shot. Do you think we're going to need a fourth vaccine dose? Is there enough evidence out there that would support what the Israeli health authorities have done now with their most vulnerable patients, which is to recommend a fourth dose?
Yeah, it's a difficult question. Let me talk first about more of the general population, and then we can get into more specifics about higher risk patients. But I would say right now we do not have enough data to recommend a fourth dose. I think what is meaningful clinically to me, and what I would advise everyone out there, is that success from a vaccine and success from a booster is preventing severe infection, hospitalization, and death. I think we have to get past the idea that vaccines are going to prevent infection altogether. There's very few vaccines out there that have prevented infection altogether. But I think when we're talking about having severe infection, which leads to a lot of health consequences and complications, as well as potentially dying from this, vaccines are extremely effective. So when I'm looking at the data to see whether someone needs to be boosted a fourth time, I'm really looking at how many of those patients that are boosted once are developing severe infection, how many are dying from COVID. And that number is still very low, which extremely low, which makes me think we're not quite ready yet to do a fourth booster. The other thing we take into account is antibody levels. So over time, our immune response tends to wane to a vaccine. So, the CDC and other groups are monitoring kind of the immune response of those patients that have been boosted, seeing what the level of antibodies are and other T cell factors in the blood, and then making a good scientific decision based on that data. So I think it's both the real world clinical data as well as some of that benchwork data that's guiding this. And we're just not there yet in terms of enough evidence to suggest a fourth vaccine. Now, I do think over time we probably will. It could be like the flu where we get an annual booster. But right now I probably wouldn't recommend a fourth shot yet. I don't know, Caesar, if you have anything to add. But there are, I guess the one thing I would add is there are certain populations that may be at much higher risk and maybe can't mount as good of an immune response. Like if you're severely immunosuppressed, maybe due to an underlying immune condition or chemotherapy from cancer, there may be certain populations that could benefit from raising those antibody levels a little bit higher. But in general, I don't think we're there yet.
Yeah, and I yeah, and I was going to ask you, you know, for the vulnerable patients, especially the elderly or those who have comorbidities, if you think, you know, fourth dose will be useful. And absolutely, there aren't enough data to kind of come to a conclusion. I'll tell you anecdotally, in the emergency department, the sickest patients I've seen with Omicron have been ones with comorbidities and not boosted. So to your point again, they're at higher risk and they're not boosted. And you know, they're coming in kind of like what we saw with Delta, which is the low oxygen. And we're also seeing, obviously, and this is connected to vaccines, which is patients who had decided not to get vaccinated at all. They're coming with severe illness. Mm-hmm. So the question of whether, you know, if Omicron had arrived before Delta, whether we would have thought that Omicron was more severe than Delta because we didn't have the same vaccine rates that we have today.
Yeah, and with that said, I do think as a population we need to get much higher with the vaccinations. Not, I think in order to really achieve good protection on a population level, we have to get into the higher 70-80% range, and we're still hovering in the lower 60% range as a population. So, and that also includes vaccinating other parts of the world too. I think that's really important because, you know, we're so interconnected in today's world with travel and everything. And as we've seen with Omicron, a variant that starts in another part of the world will be at our back door within, you know, hours of a plane ride. So this stuff's very contagious, and I think that's why it's also important to vaccinate the rest of the world, because every time this virus spreads, it replicates. It makes more copies of itself, and every time it makes more copies of itself, it has the chance to produce mutations, and it's those mutations that then could potentially lead to more severe disease, more infectious, transmissible variants, and ultimately evade our current therapies and our current vaccines. So I think if we really want to tackle this, we have to do it on a global scale.
Yeah, I couldn't agree with you more. It's kind of, it shows our interconnectedness and our own kind of shared humanity that often gets missed when we're talking about, you know, local illness and death rates in each country. It's really global death rates that we should also keep track of. I'm going to jump around a little bit to some of the questions that were submitted before. So do COVID-19 tests detect the Omicron variant?
Yeah, I mean, Caesar, I'd love you to weigh in on this because you've done so much work and looking into all these various tests. I'd love to hear your opinion, and I'm happy to contribute my 2 cents too.
Yeah, absolutely. So the short answer is yes, that our tests do a good job detecting the Omicron variant. There are a few caveats on that. One is that the antigen tests may be slightly less reliable with this variant than what we're seeing with Delta and the Alpha variant. And it's unclear to me exactly why, but the FDA has shown us, or has even set out policy statements that certain manufacturers who've created antigen tests, that their tests are no longer reliable with Omicron. It's only 2 that I can think of off the top of my head, but they're important to, you know, for our audience to check before purchasing one. The other, and obviously, you know, if Carbon has made a recommendation about an antigen test or a PCR test, NAAT test, we would obviously recommend ones that are FDA authorized still and are effective. I think the other kind of interesting thing about Omicron is that there's some evolving data that people that the virus actually peaks earlier on in the infection and lingers a little bit later in the body, which brings into question the CDC's recent guidelines around, if you test positive, you kind of isolate, quarantine for 5 days, and then you go back to work with the mask on. And I think the data out of Japan, which Aaron, you shared with me last week, really put into question that policy. And I know that the lively debate that the carbon doctors and providers had around this immediately after the CDC recommended their 5-day quarantine plus 5 days of masking kind of touched on this. Like, is that really a good approach, or do we need to test to get back into the workplace? I'm curious whether you have additional thoughts on it.
Yeah, I think there's been a lot of debate in the medical community at large too about this recommendation, and I think, quite frankly, a lot of physicians have expressed that there may be a role for antigen testing if you are going to shorten the isolation period to 5 days. And then if it's still positive, then, that kind of suggests that, maybe you need to go the full 10 days until you clear someone, because you don't, even though someone should still wear a mask, and a good mask at that, there's still potential for transmission, even with the good masks, and especially if you're at the workplace and you temporarily take off the mask, or you use the restroom, or you eat lunch or something. There's a lot of potential moments in time where you could spread the virus. Now, I think it's also important that if we are going to do a repeat test strategy to shorten isolation, we pick the right test. I don't think every test is good for that sort of use case. And what I mean by that is, some of our other tests, which we use regularly for diagnosing purposes, like NAT, you may have heard NAAT, of which PCR is a version of that. Those are very good for diagnosis. I mean, they can pick up very small amounts of RNA that the virus sheds, and allows you to detect the virus and make a diagnosis. They unfortunately aren't as good for clearing a patient when they are actively ill, because those particular tests can be positive for weeks after someone is no longer contagious. And the reason for that, not to get into too much technical detail, but the reason for that is those NAT tests and PCRs, like I mentioned, can make a lot of copies of any RNA that's detected in someone's body. But just because there's RNA, which is the genetic material of the virus, doesn't mean there's actually active virus there still. It could just be like you kind of shed dead skin sometimes, it doesn't necessarily mean it's live active skin. So whereas the antigen tests antigens are a part of the virus, and they're only produced when there's active replicating virus that's still in someone's system. So that's why for this kind of use case, a lot of people have debated, should you just use an antigen test and not one of the other tests in order to not prolong isolation, but still give some reassurance whether you're making a good decision to release someone from isolation. I don't know if you have any comments on that, Caesar, at all.
Yeah, I think that's a really important point, which is if someone's been infected within a month, and you're deciding to let them come back to work, that they need a negative test to go back to work, antigen would be the preferred second test. The preferred first test is probably NAAT or PCR, just because it's a higher sensitivity and specificity. But to the return to work strategy would be antigen for those who are previously infected. If someone's not been infected, you can still use the NAAT test as a screening tool, as an effective screening tool. So So I think that's a really important caveat that with all the different, tests that are out there and everyone's, every person has had to be like a junior scientist with this pandemic, but it's important to kind of understand when one test is more useful than the other.
Yeah. And I would also say antibody testing, in my judgment, doesn't really have much merit at all currently. It doesn't, antibody testing just lets you know that either you were vaccinated with COVID vaccine or you had COVID at some time, but it doesn't tell you anything about whether you're actively infected or whether really, we don't really have a lot of data to know, to use that to guide us whether someone should get a fourth booster or at this point. So I would just say antibody testing doesn't really have a lot of clinical utility today. Now it may in the future, it just doesn't right now.
And my understanding is that at least with the generation of antibody tests that I looked into, that they weren't specific enough to COVID or the COVID variants, that it was the general kind of coronavirus, which is the common cold, as well as the ones that we're worried about with this pandemic. But at least the ones that I've run across, I'm not sure if you've seen others.
There are some that are more specific, but again, I'm not sure how it would change our decision making.
Yeah. That's really helpful. So, okay, I'm going to go on to some more of the questions. If Omicron is mild, do I need to be worried about it? Should I still be cautious if we think that we're all going to get COVID anyway?
Yeah. I mean, personally, I would say yes, you still do. One, like we mentioned before, there's a wide spectrum of individuals based on their genetics, based on their underlying medical conditions. We never know how someone's going to react to any of these variants. And I think, I've taken care of a lot of these patients in the intensive care unit, and I've seen some very young, healthy people end up on ventilators and unfortunately passing away from this. And so again, we don't know how any individual is going to react to it. We also know there are a lot of vulnerable people in our society who either have significant underlying medical conditions that we need to try to protect and not spread it on to them. But also vaccines aren't approved yet for our very young pediatric population, So I think that's another age group that's not protected, and we need to be careful not to spread to them. I would say the third thing is this long hauler syndrome, which we still don't know a ton about. It's an evolving field, but some of the symptoms that people experience are incredibly debilitating to the point where they can't go to work, they can't function well, they get cloudiness of the mind, they call it brain fog, they get pain, they get different vital sign changes sometimes where their heart rate speeds up and down and blood pressure changes. It's called autonomic instability. They get shortness of breath, incredible fatigue. And some of those cases are in people that only have very mild COVID courses. So just because you have a mild course doesn't mean you can't develop certain long-term issues from COVID. So I think for all those reasons listed, I think we still have to take this seriously. And the last thing is, if we keep spreading it, if we aren't cautious about this, like I mentioned before, every time you spread it, the virus replicates, and every time it replicates, it has a chance to mutate again, and then we may get a more severe variant again down the road. So I think if we all want to do our part, really getting this under control, then we have to take these seriously.
Yeah, and I'll maybe add to that a little bit, which is on Monday, so just this very past Monday, I was taking care of a patient in the emergency department who was a gentleman in his 50s who came in with low oxygen saturation in the 80% range. He had been sick with, what ended up being coronavirus. So he had COVID for about 10 days, actually. And he said he was getting better around day 7. And then from 7 to 10, he was feeling short of breath to the point where he couldn't walk, and then eventually had to call the ambulance. when I asked him about his vaccine status, he said he wasn't vaccinated. He was not vaccinated. And the reason is that he had a family member who was vaccinated, who ended up getting COVID, so catching the virus and feeling pretty sick with it. That person, that family member of his, didn't die, wasn't hospitalized because he was vaccinated, and had enough protection. But it was enough for this gentleman to decide that he didn't need the vaccine. Well, if I'm gonna, if the vaccine doesn't protect me from catching this, why would I accept the vaccine? And so it was a really, illustrative, example of why there's potentially a misperception in the US around what the vaccine can and can't do, which is that the patient I saw on Monday ended up having to be hospitalized because he never got the vaccine. And I don't think it fully clicked until that moment for him, that the vaccine would have probably saved him from having to have this severe version of the disease. So for the family members, I would really encourage you to kind of think about that example, real world example, if you have family members who are pushing back.
Yeah, and I would also say, there's been well documented in the literature a lot of complications that have been associated with COVID-19 infection, even more milder forms. So everything from blood clots in the lungs and legs to bacterial pneumonias on top of the COVID to heart failure. I mean, there's a lot of ways in which this virus can impact the body and lead to other medical conditions. So I think it's important to be aware. We just don't know how any one individual is going to react, and so it's important to be cautious.
Yeah. Actually, speaking of that, I'm not sure if you saw the data CDC put together from hospitalizations in California and New York, comparing the different vaccines. So comparing Moderna to Pfizer, and then actually looking at people who had been vaccinated and also infected. But it looks like again, on the population basis, that Moderna was slightly more effective at preventing death and hospitalization as compared to Pfizer. And it was much better than Johnson & Johnson. And at least in this study, it looked like that people who had gotten coronavirus and had been vaccinated. So this goes to the question that we often get, which is, look, I already tested positive for coronavirus. I had some mild symptoms and I'm better now. Why do I need to get vaccinated?
Yeah.
Well, the CDC is actually telling us now that the people who caught coronavirus and were vaccinated actually had the lowest rate of hospitalization and illness compared to vaccine alone. So it doesn't mean to go out and get, don't try to go out and catch coronavirus, but if you have been infected and you're questioning whether or not you still need to be vaccinated or vaccinated and boosted, it seems like the answer would be that you should still get the vaccines.
Yeah, and there have been other papers too, even before this Omicron wave, where they looked and compared those that just developed native infection and what their immunity and recurrence rates were versus those that got vaccinated and what theirs were. And what all these studies are showing is that vaccines have added benefits to just getting the virus alone. The reason for it is they're designed in a way that does two things. One, they build antibodies and T-cell responses that work against a broader range of potential variants. So when you get infected with, let's say, a particular variant, your immunity may be very good for that one variant, but it may not be as good for future variants. Whereas we've seen time and time again with the vaccine, it tends to work across a broader range of variants that emerge in the future. And the other thing too is it tends to generate a more robust immune response, meaning it gets your antibody levels higher, and it really primes your immune system to a point where you can fight these future variants better and for a prolonged period of time compared to just native infection alone. So I think there's certainly added benefit if you've had coronavirus to still get vaccinated and boosted. If you've never had it, to get vaccinated and boosted. There's really, the data time and time again are showing that.
Yeah. I'm going to maybe read off some of the questions that we have from this Q&A as well. So I'll take the first one, which says, hi, we do our weekly testing for unvaccinated staff through Carbon. Can we schedule weekly antigen testing for staff who have tested positive? Without knowing exactly, where you are and who wrote this, I can say that we just secured somewhere on the orders of tens of thousands of antigen tests specifically for this purpose. So that's the degree of information that I have on antigen tests through Carbon. But again, because of this need to be able to go back to work for those who previously tested positive, et cetera, or want to make sure that they're not infectious to others, we have secured a large supply of antigen tests. So hopefully that'll be coming soon for your organization. And then, have you seen any COVID patient data that show liver enzyme increases? Not sure, Aaron, if you have. I have anecdotally heard that people will get temporary bumps in their liver enzyme. So that's the AST, ALT. And I don't think I've seen bilirubin increases, or heard of that, but I have heard of this like really temporary bump and then decline. I'm not sure if you've seen.
You're saying with infection.
Sorry, with yes, exactly, with infection. With infection,
yeah. It's actually not that uncommon to see bumps in your liver function tests that normalize once you run the course, unless you develop severe COVID, where sometimes you can go into liver failure. But it's not uncommon to see mild elevations in those numbers. Just like a number of the inflammatory markers that are sometimes tested tend to go up as well. Sometimes we've seen amylase and lipase, which could be a sign of inflammation in the pancreas, also go up. But this virus affects a lot of different organs and tissues, so it can a lot of times make those lab values also go up.
Great. Yeah, and then so this last one, which I'm going to read just to make sure I understand the question. So what is the likelihood that someone who catches Omicron does not infect someone that is not vaccinated? In other words, is it possible for an unvaccinated person to not catch Omicron after they've been around someone that has Omicron? And yeah, so I guess this question goes to transmissibility. Like, if you're unvaccinated, are you guaranteed to catch Omicron if you've been around someone with Omicron? I think we can answer that one.
Yeah, I think, well, it depends on different factors, maybe whether the individual had COVID very recently, and maybe has some immune protection from that. But I would say it's incredibly contagious. So it's pretty rare to not catch it. You really don't need a prolonged period of time in a room with someone to get Omicron. So I would say that the chances are very high someone would contract it.
Yeah, it's not 100%. Nothing really is in healthcare medicine, but the odds are that you will get infected. And anecdotally, we've seen patients who've had very close contact and been lucky, and we've had families that have lived together where 4 out of 5 people get infected, and we don't really understand why the 5th person didn't. We've also seen very brief interactions between people where everyone gets infected. And so it's hard to say all the factors that go into that. Here's a question about, it's just kind of really important and probably in the back of all of our minds, which is this the end of the pandemic and the start of the endemic? portion of for coronavirus? Like, is this the beginning of the end? I think is the question that's coming out.
You want to take the first stab at that, Caesar? You get out your crystal ball and.
Yeah, well, I remember in doing these webinars in April of 2020 and saying that humans and coronavirus have coexisted for tens of thousands of years, most likely. And that we both kind of adapted to one another, right? So the coronavirus adapts to infect humans. Humans have been able to somehow survive coronavirus through the ages. And so the question to me is, will we get into more of an equilibrium with this virus over time, where it's not killing roughly 1.5% of people who have been infected, which was kind of the early data that we had, and getting back into this homeostasis with the virus. My guess is that we will find equilibrium at some point again. Whether that requires us to be vaccinated and use our technology to survive, I'm not quite sure. But what I'm hoping is that we'll have milder and milder forms of the coronavirus coming out. My fear, though, is as we're seeing in Denmark and that there's a new variant that's coming out that's severity is to be determined. And so as these additional variants come, it's almost going to be let's wait and see how severe they are. So, yeah.
And I think, yeah, you're absolutely right, Caesar. I think we're still at a high risk period of time because the spread is so great around the world that, more variants will emerge, more mutations, and we just hope that a more severe one doesn't take hold. So I think we're still in a vulnerable period of time, but I think you're right. Over time, we will transition to more maybe of a seasonal sort of, or certain time periods where we see spikes, whether it's the winter time period where people are gathering inside and around the holidays and things like that. It could take on more of that form, but I still think we're in a highly vulnerable period right now where we just don't know. And I think if you wanted to look at viruses from kind of a macro evolutionary standpoint, the goal of a virus is to be contagious so it can spread and so it can live on in society, but not to be deadly enough where it kills its host so it doesn't have that chance to spread and replicate and live on. So I think viruses over time tend to evolve to an infectious strain, but not necessarily as deadly of a strain. But when that will happen is anyone's guess still.
Yeah. Well, actually, and it brings up this other question, which is really good to hear. But well, if you get coronavirus, so if you get COVID, can you catch it again, or are you kind of done?
Yeah, you can keep catching it, unfortunately, and some of that depends on, definitely new variants you can catch again. We've seen that time and time again. In terms of the same variant, we have seen reports of that happening. A lot of times it depends on one's own immune response, other factors, period of time between when they had the infection and then when they caught it again. So there's multiple variables, but short answer is yes, you can catch it multiple times.
Yeah, and I've seen that in my patients as well. So so we've had, with this recent wave, we've had large number of patients who come in, test positive. And we always ask, are you vaccinated? Have you been infected before? And there's a small percentage of them who said, yeah, I've had, this is now my second time being diagnosed with coronavirus. And the potential kind of silver lining is that, at least anecdotally, and I don't know if there are data to support this, Aaron, but at least anecdotally, the repeat infections in my practice have been milder versions of the infection. I think that's anecdotal and we don't know, but curious whether you've heard anything different.
Yeah, I want to be careful saying that because I've definitely seen the contrary to that.
Oh, you have?
So
Okay.
yeah, so I don't want to give people a false sense of
Yeah.
protection. But you know, I think we still need larger scale data to know whether that's true or not in a general population.
Yeah, so maybe that bears repeating then, which is that just because you've had coronavirus once, doesn't mean that if you catch it again, that you won't have a more severe course of it.
Right.
I think that we just don't know. And therefore, it probably behooves us to still be careful in spreading or catching this virus. Yeah. Yeah, perfect. Well, I've gone through our questions. I think we're out of time, and I don't see any more questions in the Q&A, but really appreciate everyone who's joined and listened. And if you have additional questions that come up later, please feel free to ask your CSM or any other person that you're interfacing at Carbon, and we'll be sure to try to answer them. Great. Well,
Thank you everyone for your time.
Yeah, thank you. Have a great rest of your day.